This podcast is brought to you by Key4Her. Whether you're feeling the effects of menopause or your menstrual cycle, discover what's key for you in less than 5 minutes. With tailored supplement recommendations, information and insights on key4her.com.
Hi, I'm Renee.
And I'm Donna. Welcome to the Key4Her podcast.
In this series, we aim to educate and open up honest conversations with both medical professionals and real-life women.
We want to shine a light on those topics that sometimes go unspoken about and help empower women to know what is key for their health and well-being.
This is the Key4Her podcast, and my name is Dr. Caoimhe Hartley. Today, we are speaking again to Dr. Michael Crotty. Mick is a GP with a specialist interest in bariatric medicine or weight management, and he runs the My Best Weight clinic, which is based out in Blackrock. Mick and I have been married for 10 years, and apparently we still have lots to say to each other, so hopefully you enjoy our conversation.
There's science to this, there's biology, there's genetics, the environment is contributing, fad dieting, intermittent fasting, moving more, eating less isn't going to necessarily be the answer to long-term sustainable weight loss. So what is?
Oh, this is
$1 million question, Mick, exactly. On the spot. Go.
So I think again, we one of the biggest things is sharing that understanding that, somebody is not necessarily doing something wrong. It's not their fault. And I think, the way we talk about weight, the language we use, kind of not blaming and shaming. So that's kind of part one. And then we can talk about, okay, well, if somebody feels that their weight is having a negative impact on their health, and this is a medical issue, and they have the chronic disease of obesity. Now, again, that word obesity can be a real trigger to some people, and a lot of people don't like that word. But when I'm talking about obesity, I'm talking about excess weight that's having a negative impact on health. Okay, and that's the clinical term obesity.
But if people are listening to this saying, whether they're in that category or not, but I'm struggling and I want to lose weight. Yeah. What are their options? Like what?
So most people will have done the kind of diet and lifestyle kind of approach. So again, broadly we can break it down. We know that no one diet, no one eating pattern is any better than another long term. Okay, so we can accept that people can lose weight, the weight will come back. Most people have tried those things. So when I talk about treating this medical issue or managing this medical issue, we talk about the 3 pillars of bariatric medicine. Okay, so this might be an awakening for you, or enlightening. So we talk about kind of behavioral intervention and behavioral support. We talk about medication options, and we talk about surgical options. And they are the 3 different treatments that are available and proven by science. Because lots of people will come into me and say, I've tried everything, doc. And I'll say, okay, what have you done? And they'll talk about all the things that they've done that they've been told to do. And they're right, they've done everything they've been told to do, but they've never actually been treated or properly supported in managing their weight. So if we talk about treatment, treating kind of weight, we talk about behavioral support, medication or surgery. That's the treatment. And
so give me an overview of those 3. So what's the behavioral intervention?
So kind of conceptually, if we think about, again, just going back to my old chestnut of the kind of caveman analogy.
A lot of chestnuts.
A lot of chestnuts. Yeah. We'll have to throw in a few acorns as well. But if we talk about this kind of caveman in the subconscious brain who's roaring, and it's always a man, it's never a cave woman, but because
Why is that?
I don't know, because maybe I'm a man, and it gets me in trouble if I'm talking about things I don't understand well. So if I talk about the caveman in the back who's roaring and shouting, and he's excessively hungry, not satisfied, and he gets too much reward from food. Conceptually, we can think about medication and surgery as biological treatments to treat the subconscious part of my brain, to turn down the volume on the caveman, to reduce my levels of hunger, to increase my levels of fullness, and reduce the craving, the wanting, the reward-based desire for food.
Medication and surgery, you said, do that.
Yes.
Okay.
So that's the biological treatment.
Right.
So that's like putting somebody on a blood pressure tablet. It's like putting somebody on an inhaler for asthma.
Yeah.
It's treating the underlying
biology. The actual biology, yeah.
Okay. Obviously, if we are doing that, it's also really, really helpful for people to focus on behavioral support, which is more kind of, I think about kind of the smart lad up the front, the modern man who's making the decisions.
Again, a man.
Absolutely.
Clearly, this is a woman in your head if she's making all the decisions. Go right ahead. Yeah.
So we talk about this kind of modern person up the front.
Better.
That is we're getting very gender neutral here. So we're talking about this modern person up the front who is making the decisions, who is integrating that kind of biological drive with emotions and the world we live in. Okay, so that kind of modern person who's making the decisions, we can support that person to make the best decisions they can. So that can be, anything. That's kind of the structure of our day to day. It can be looking at quality of sleep. It can be looking at stress. It can be looking at time management. It can be looking at, nutrition. It can be looking at behavioral or psychological interventions. It can be identifying, what am
mood.
Absolutely. Mood. It can be looking at the medications somebody's on and adjusting those, because some medications can promote weight gain.
So you're looking at all those environmental external factors that maybe explain why someone is...
Yeah, and also, what are my triggers for taking in more than my body needs? When are my high-risk times? You've kind of said maybe, for some people, they're busy all day, they put the kids down, they're breathing out, they're relaxing, they're watching a bit of TV.
Leave your cup of tea.
They're generally not getting to choose what's on TV because their wife is doing that for them.
Okay,
And then, they're having their cup of tea and they get to relax. And that might be a high-risk time for snacking or craving or wanting. So again, it's identifying these things and then coming up with practical strategies for people to navigate the world that they live in. So maybe for some people, it might be focusing on having a breakfast or having a lunch, so
or
they're not
food
accessible.
preparation, I think.
Exactly. So it might be kind of batch cooking. It might be food preparation. It might be, I know that I'm commuting. I know that left to my own devices, my caveman is going to want me to stop at the petrol station and grab something convenient and tasty because I'm so busy. So maybe I'll bring something with me. Maybe I'm going somewhere for a meeting. Maybe I look at, what options do I have for restaurants around there where I can get something, maybe I'll look up the menu before I get there so I'm not overwhelmed, and I'll pick something kind of healthy that I kind of know aligns with getting me to where I want to be long term. So that's the behavioral approach. And again, this is no different from any other medical condition. So somebody comes into me with high blood pressure, we'll say to them, okay, well, obviously, we can focus on kind of salt intake, we can focus on physical activity, we can focus on stress, we can focus on time
But that
management.
will only get you so far.
Exactly.
Because a large part of their blood pressure is often genetics and aging.
Exactly.
Or,
So for a lot of people, that might be a very fine kind of treatment. But for some people, it's not going to be enough. They're going to need biological treatment. They're going to need a blood pressure tablet. They're going to need a cholesterol tablet. They're going to need an inhaler for their asthma. We don't blame them. We don't say, listen, for your asthma now, you have to quit your job, move to the countryside. You can't have any dust in your house. You have to, do all these kind of, different things. And only then will we give you an inhaler.
Yeah, no, it's a combination of...
And they don't have to fail a behavioural treatment before you offer them treatment.
Absolutely, yeah. And like anything, I suppose, that's really kind of modern general practice in a way, isn't it? That it's a combination of lifestyle interventions, but also offering people their, prescription options, non-prescription options, and letting people sort of decide what kind of route maybe suits them best.
And that's it. Different things suit different people. So this old-fashioned kind of, the doctor's telling you what to do, that's dead and buried, thank God. I see people coming into me, and they're often more of an expert in their own body than I am. They understand their body.
They would be,
and they've done research and they've looked things up and they understand. And I'm sure you get the same. Thankfully, there is a huge amount of information out there on menopause, on different things.
I do think that can be complicated though, because there's a huge amount of misinformation as well, and so people are bombarded with information. And how do you wade through that? And we find it hard enough to kind of look at scientific reviews and research and figure out what's reliable and what isn't, and how big a study is, and what's the p-value of, and all the stuff I pretend to understand that I don't. And so we end up kind of wading through stuff to figure out who we actually trust as a reliable source or not. But it's 10 times harder if you're not doing this every day. It's not your area of,
it's
skill
gas,
or whatever.
I don't know if you've ever sat in practice and I've often pulled up Google on the computer, and with the patient with me, I'll Google something. I
have never Googled anything. What are you?
You should try it.
No, do you know the trick is in general practice, if you're a female GP and if you've a female patient, ask them for a urine sample.
Okay.
It is brilliant. They get out of the room, you can pull up Google, you can double check that you're right, that your dose of whatever is correct. And by the time they come back in, you're back in their notes.
So is that why you're always right and rarely wrong?
That's why every single patient is sent for a urine sample. Yeah.
So again, I'll pull up Google and I'll be Googling something in front of a patient. And so at the start, they're kind of agog. The doctor's using Google. Sure, I could just do that myself. But I suppose we're Googling with the background knowledge of 6 years of medical school,
being able
and
to
GP
sift
training.
through.
And you can pick out the garbage from the non-garbage based on kind of your medical knowledge.
So speaking of,
it's different.
I'll move you on. What's in terms of medication, talk to me about because we've talked about behavioural, so the other two pillars, your other two chestnuts, you have medication, acorns, fine, you have medication and surgery. So talk to me about patients who would be going down either of those routes, or is it both, or pros and cons of all of that?
So again, I see my role as presenting these are the options for people, and then it's up to a person to decide what fits for them within the context of their life, within their belief structure, within what they want to do. So from a medication option, I'll talk to people. There are 3 different kind of medications that are licensed in Ireland to help manage weight. Okay, there's one called Orlistat that's been around for donkey's years.
Is that the one that makes you have horrible bowel symptoms, and it makes you poo out fat? Is that kind of my simplistic version of it? Oh God, you're laughing at me now.
That's fairly accurate. So basically, it stops you absorbing about 30% of the fat in your diet by affecting one of the enzymes we have in our intestinal tract.
Okay.
So if we don't absorb that fat, if we take something fatty, that fat has to go somewhere, so it's going to go out the other end. Okay.
That doesn't sound in any way pleasant.
It's not very nice.
No.
I rarely prescribe this medication, if I'm honest. It's been around for a long time, and it's actually available as an over-the-counter version as well. But
is it effective?
It is effective in the short term when people use it. I have yet to meet anybody who has been able to use it long term.
Stay on it. Yeah. Okay.
So from bloating, diarrhea. You might be able to tell me what the medical term for sharting is, but it's exactly what it says in the tin. It's follow through leakage.
You just made a face.
The detergent bills in the house kind of go up, and whoever's scrubbing the underpants has a difficult job.
It's not you.
It's not me. So you could teach me. So basically, that medication reduces our absorption of calories, and as a result, people, absorb less calories, and it creates a deficit and weight comes down. The problem is, staying on it long term in the face of all of these side effects.
Nasty side effects,
it's not very pleasant.
So what are the other two?
So the second option we have is a tablet called bupropion combined with another medication called naltrexone in a tablet form. It's taken every day as an oral tablet. Bupropion is an old-fashioned antidepressant. It has been used in the past to help people stop smoking as well. So in our caveman brain, it has an effect on reducing levels of hunger. It also has an effect on craving and wanting for food. So we're now actually addressing the underlying biology that's going on. They've combined that with naltrexone, which is a morphine receptor blocker. Okay, so if you might cast your mind back to when we worked in hospitals and somebody comes back from theatre and they've had too much kind of morphine and they're very groggy and their breathing is laboured, then we give them naltrexone to reverse the morphine. And all of a sudden they're in kind of pain again.
Back of my head,
So at low doses, this morphine receptor blocker blocks some of the pleasure receptors in our reward pathways. So as a result, we get less craving and wanting and desire for food. So the net result of this is a reduction in our desire for certain foods, our change in our kind of preference for foods, a reduction in our hunger levels. So it's a tool that facilitates the behavior change of, monitoring our intake. So really, like I say, it kind of quietens the caveman so the smart person can make the good decisions.
I feel like I don't hear you talking about those two medications as much as others though. So
there are challenges, and obviously for anybody talking with these medications, they would have to have a detailed medical assessment. They'd need to talk through their specific issues. This is not just kind of take the medication and you're done. There's also certain people who the medication may not be suitable for, and then like anything, there are potential side effects from these medications as well.
But what do you like to prescribe?
So that's the second medication. That's a very fine medication. The challenge of it is taking tablets every day, and actually at that medication, the usual dose is 4 tablets a day. So that can be challenging for people to take every day. So the third group of medication we talk about are medications called Glp1 medications.
Yeah.
So glucagon-like peptide 1 is a fullness hormone. Hitting with the science here.
You big show off. Yeah.
I wrote it down beforehand and learned it off. Mm-hmm. So GLP1 is a fullness hormone. So when I eat, my intestine produces GLP1. It communicates with my brain to tell me I'm full.
Okay.
In its natural form, it lasts maybe 90 to 120 seconds, a minute or two in our circulation, then it's gone. So that's why I can have my dinner and I can feel full and I can be grand, and then I wait a while and
then you can have dessert.
I discover
Does that explain
my second wind.
stomach? Yeah.
Exactly. My kind of second wind, my fullness hormone has now gone away. I'm no longer full and I can have some more. And again, like I said, people who struggle with weight, we don't have as much of these kind of fullness hormones. So essentially by giving somebody a medication that is almost identical kind of chemically to these hormones, it communicates with the brain to make us feel fuller quicker.
Okay.
We feel fuller, we feel more satisfied by food when we eat. So I can't eat as much because I feel full. And for some of my patients, they come back and they say for the first time in their life, they know what fullness feels like. And this is like mind-blowing, miraculous change in their life because they've never experienced this. And they invariably come back and say, is this how other people feel?
That's amazing,
Is this how people who don't have an issue with their weight feel
Yeah.
normally? And I said, yeah, this is why it's not a level playing field. You're dealing with a whole different deck of cards from somebody else.
Yeah.
So again, they come back and they say, this, for some people, it can be a miraculous change. So they feel fuller quicker, less hungry. We're not thinking about food as much. Well, we can eat and we can enjoy food, but we don't get the same kind of levels of craving. So again, it's back to the caveman and kind of quietening him so that the smart person who knows about nutrition, who is intelligent, who knows the things they want to do, is better able to apply those day to day without getting bombarded by the subconscious drive.
Okay. So effective, obviously.
Mm-hmm. So
okay. Pitfalls?
So response with any of these medications, response is variable. Okay, so we have lots of evidence. So particularly these GLP-1 medications, they were actually invented to treat diabetes many years ago, and they work really well. So aside from the effect they have on weight, they have a really good effect on insulin, on blood sugars. There's potentially a good effect to blood pressure. They're trying to figure out.
So there's some health
There's
benefits.
potentially a benefit to the heart and the liver. So there's lots of health benefits. There are certain people they're not suitable for. If somebody has a history of pancreatitis, we don't use them. If somebody currently has gallstones, then we're cautious with them. And there's a rare type of thyroid cancer that if somebody has it in their family or has had it themselves, then we often avoid these medications. So again, this requires kind of an assessment by a doctor, a healthcare professional to see if they're suitable for them.
Do people stay on these for life, or is this something you could take for 6 months, get your weight down, maintain that then with your lifestyle?
Yeah, so this is kind of the kicker of it all, and kind of, you end up kind of hitting people with this, is that this is chronic disease management. This is chronic medical therapy. These medications will work for as long as we take them. They will treat the biology. When we take them with variable response, weight will come down and ultimately it will plateau.
Yeah.
Our body won't let us continue losing forever. And where our weight plateaus is different for everybody. Some people have a very strong response. Some people have no response. And again, that's not their fault. It's just purely their biology and their genetics.
Yeah.
When we are on these medications, if we stop the medication, the biological protection is gone. So again, going back to that thermostat, that set point, our weight is going to want to come back over time. But again, if we think about other medical conditions, let's say high cholesterol, let's say asthma, let's say blood pressure, it's no different. So if I need a tablet for cholesterol because genetically my cholesterol is too high, that will bring my cholesterol down. If I stop the tablet, my cholesterol is going to go back up again.
But we have both met patients, infuriatingly, who come in and you check their blood pressure and it's gone up, and you think, okay, well, you're already on 2 blood pressure medications, we're going to have to add in a third, and you have the conversation and realize that they've stopped their blood pressure medication because without knowing, with the best of intentions, they felt, well, sure, every time I've got my blood pressure checked in the last year, it's been normal. I didn't, and maybe they've made some lifestyle changes. I didn't think I needed the medication anymore. But these are lifelong issues.
Again, their blood pressure is normal because of the combination of the medication and their
Isn't it so easy to fall into that trap, though, of thinking, but I feel really well.
And again, we are brainwashed to think if I just get my weight down, I'll be able to
sustain that myself. Yeah.
And again, going back to these studies, in all the studies where they looked at these medications, when the medications are stopped, weight comes back. But again, when we understand the biology, when we understand kind of why that happens, it makes perfect sense biologically. Because again, these medications are kind of treating the biology. They're helping us regulate and control our weight. But it's not like taking a course of antibiotics where we're all of a sudden cured of...
You're fixed.
You're fixed. This is, we're not changing people's genetics. We're not changing the structure of the brain. We're just managing the symptoms to facilitate them living the healthiest life that they can to improve their health long term.
So do you have to set expectations a lot? Do you think people come in and maybe they have some response, they lose some weight, and then they get disappointed if they're stuck or they plateau?
Yeah, and I think
that must be challenging.
From the offset, I suppose, helping people understand that response is variable, that not everybody will respond, that side effects are variable. Some people might have worse or no side effects, that kind of ultimately our weight won't continue coming down forever. It will plateau, and statistically we can look at where that might be for people, but each person is an individual. You know, if they have never been treated before, we don't know where it's going to end up. And then that this medication needs to be continued long term to maintain. And that's why things like bariatric surgery are so effective long term as well, because that's a permanent treatment.
So who goes for bariatric surgery versus medication? How do you help patients make that decision?
So again, it's a case of, now you can talk about kind of eligibility. So from an eligibility point of view, bariatric surgery in Ireland is probably reserved for people who are more severely affected by weight. And there are different criteria. Unfortunately, the insurance companies and a lot of people still base the criteria on body mass index. And, you know, somebody has to have a weight above a certain level before their insurance is covered or before they'll be suitable for bariatric surgery.
And a lot of people go abroad, don't they?
And again, you can understand, you know, people are desperate for treatment. People are desperate, you know, to help kind of improve their health. And because of that, people go abroad. And there are many challenges with that. Again, you know, exactly the same way as medication is not a one and done kind of cure fix, bariatric surgery, the intervention is, the surgery part is relatively short, but it is a lifelong treatment. People need support. They need to be monitoring nutrition. They need psychological support. They need to remain on kind of multivitamins and mineral supplementation long term. They need blood work done. So this is long term chronic disease management.
Possibly a stupid question, but
there's no such thing as stupid questions, just stupid people.
Oh, okay, no pressure. Thanks for that. If you have gone away and travelled and if you've had bariatric surgery wherever and you have your weight loss, and going back to what you were saying about this, you know, set point, well then your weight over time might strive the hormones will change to kind of drive you towards weight gain. Is there a role for bariatric surgery and then maintaining that weight loss with medication?
Yeah, so it's very variable. Response to bariatric surgery is different. And again, even just to kind of go back to how surgery works, because this is one of the myths. We talk about stigma and kind of bias in society. Bariatric surgery is hugely stigmatized. You know, people think, oh, you're taking the easy way out. You're taking a shortcut.
Like it's a cop-out.
Like it's a cop-out. Well, is it a cop-out to take an inhaler for my asthma to stop me coughing and wheezing? No, it's not. It's a treatment. It's evidence-based and it's safe. Bariatric surgery is a fantastic treatment. It's really, really good. How it works is by changing the anatomy of our stomach or intestinal tract, we change the levels of hormones that communicate from the periphery with our brain. So the levels of hunger hormones.
Through surgery.
Through surgery. The levels of hunger hormones, the levels of fullness hormones. So it's all treating the brain. Okay, so the brain is the center of all of this. So bariatric surgery is not just shrinking somebody's stomach, it's changing the hormones that regulate hunger, fullness and weight in the brain, and that's what facilitates weight coming down.
And for some people, is that lifelong, that they don't need anything?
Yeah, so for some people,
other medical intervention.
Absolutely, but they need to be monitored for kind of, you know, not absorbing certain minerals, you know, their bone density, risk of fractures. We know that for some people, things like kind of addictions can go up after bariatric surgery. Again, because we don't know why, but again, in the brain and the complex stuff that's going on in there, you know, it needs long-term follow-up. So again, you can totally understand why people are going abroad, but the problem is, you know, some people are going abroad and they're not telling family members, they're not telling their GP or doctors they've had it done. And again, that can be, you know, dangerous because, you know, it can, if people don't know it's been done, then it can affect your medical care.
Isn't that awful that it's driven by stigma and shame and fear and
again, it's a case of it's going back to this, you know, everybody seems to be kind of on a journey these days, you know, between kind of, you know, mix whatever journey along whatever way, you know, it's social media, it's driven, we're conditioned to these kind of before and after body transformation. We want, you know, the changes, and everybody's response is different. So some people come back disappointed, they don't have the same response from surgery, somebody else, or the same as the medication. All these things are kind of used to sell things to us. But again, you know, I think bariatric surgery is a fantastic medical treatment. My preference would be for people to have it done here in Ireland, where they can be appropriately followed up by specialists, by dietitians, by psychologists, by their GP. But again, I suppose GPs are being bombarded. You know, as GPs, we are usually kind of, we know a little about a lot, but we're not experts in kind of following people up post bariatric surgery. So the people who come back and tell their GP, it's brilliant that they tell the GP, but the GP, you know, then might be kind of a little bit at sea as to kind of how to appropriately follow that person up.
Sure.
Now, GPs are upskilling and all these things all the time, but the concern is about the people who come back and don't tell. You know, and, you know, they might have complications or issues where they can go for kind of support. So again, it's a brilliant treatment. Some people will respond very well to behavioral intervention. Some people will respond very well to medication. Some people will require surgery. But these are all kind of on the table. And some people who kind of go on medications will ultimately want to have surgery. Some people who have surgery may down the road, because of, again, complex mechanisms, regain weight. They'll rarely go back to the weight they were before, but they may have significant weight regain. And again, can you imagine the what a knock that can be to people
after going through all of that?
After going through all that, and people are regaining weight, and the blame. But again, this is biology.
This podcast is brought to you by our very own brand, Key for Her. Whether you're feeling the effects of menopause or your menstrual cycle, discover what's key for you in less than 5 minutes with tailored supplement recommendations, information and insights on keyforher.com.
Please have 20% off on us by using the promo code KEYPODCAST in all capitals.
Do you like your job?
Love it.
What do you not like about it? Bad points. Because you're funny, you're a bit of a weirdo. You qualified, and then before we met, you did your surgical training. So you did the basic surgical training, and you did your memberships, didn't you? Yeah. And then, you pivoted and went into general practice.
Thank God I did, because I wouldn't have met you otherwise.
Now you're saying all the right things. But you were as past tense, you were a brilliant GP. You are a brilliant GP. Lest we forget, he came first place in his membership exams of the Irish College of General Practice.
About that more than I do.
Well, that's because I did not come first place or anything like it.
You have to say about a stop clock is right twice a day or something. But.
Anyway, and then when we were in Canada, that's kind of how you've kind of fell into this area and of weight management. I'm just sort of curious, like what, because we never really sit down and pick this stuff through, but like, what don't you like about your job? What are the challenges? So on a day-to-day basis?
On a day-to-day basis, the challenges are that the treatments that are available, so let's say medications and surgery, are not available to the level they should be. They're not prioritized, they're not resourced, they're not reimbursed.
Whose fault is that?
It's not anybody's fault, but I think it's a lingering kind of belief that our weight is our own personal responsibility and you should just be able to take care of it yourself. It's kind of the bias that kind of 88% of people who are kind of living with obesity report that they have been blamed, shamed, and abused as a direct result of their weight. So this is ubiquitous every day in society, in healthcare, in the workplace. It's the last kind of area. People are not judged based on their age, their sex, their skin color, their religion, but by God, they're judged based on their weight, and there's assumptions about them, and it's totally unfair. And that kind of still permeates in kind of healthcare. And some people might be with a doctor who maybe isn't as educated, because none of this kind of stuff we've been talking about, I didn't learn this in college, you didn't learn it in college.
Absolutely not. No.
I didn't learn it in my GP training. It's only something I've come to later on, and that's why it was like a eureka moment for me. Number one, I suppose I gained an understanding for why I have struggled with kind of weight myself over time. I gained an understanding of kind of how I'm like the born again Christian, or I'm like the kind of reformed alcoholic. I have been that GP who has, told people to just eat less and move more. And like when I cast my mind back now, I'm utterly ashamed that was me, but I knew no better. So that's why I'm kind of passionate about trying to educate kind of healthcare professionals on why we need this different approach. And it's not people's fault, because I have kind of fallen into every hole that it is possible to fall into on this. And I have blamed and shamed people. And that's why I think kind of I have to remind myself every single day, I might be talking about this repeatedly over and over again with different people, but it's the first time people have often talked about this.
We talk about that a lot because we're similar in I'm GP, obviously, in my background, and then subspecialised to women's health, and obviously I do mostly menopause. And every time I have a first visit with someone, it's sometimes you're telling them information, I hope, that they maybe didn't have before, and you're opening their eyes to how some of how they feel isn't their fault, and there is kind of biology behind this, and dispelling some of the myths that are out there about, in your case it would be fad dieting, or in my case some of the myths about HRT, for example, etc. And it is easy to forget, okay, this is the 6th or 7th first visit I've done today, and you're running through a lot of the same stuff, but it's the first time they have heard this.
And imagine how brave somebody has to be, and how vulnerable kind of people feel talking about these very intimate, very personal issues that have been huge in their life. Now, again, it might be run of the mill for me to talk about this, but this is the first time that person might be properly talking about these things. And that's why the environment and how we have the discussion is so important, to help kind of support people in a non-judgmental way, and to give them the information. Like, these are smart people, to let them kind of make the decisions. And I think we constantly have to remind ourselves what a privileged position we are in, that kind of people come and share their kind of life experiences and the trials and tribulations they have had. And we get to support and help people and give them the information, and I think that we're kind of, very lucky in we can do that. And that's why I find this kind of so fulfilling. And certainly when I'm talking about weight, people come back, and if I'm honest, I could not give a flying hoot about... I was
worried about what you were going to say there.
I kind of had to stop myself for a second.
I could see that,
I get a bit carried away sometimes. I have to kind of, I'm not bothered nor interested in the numbers on the scales. That, to me, is one of the actual poorest indicators of success when it comes to weight management. And that seems weird, and that seems counter to kind of the way we are trained, where it's all about get up on the scales there and we'll see if it's working.
Yeah.
The non-scale successes that people talk to me about, the increase in energy, the improvement in sleep, one of the biggest things is the no longer constantly having to be dieting, not restricting, not being miserable.
That relief.
Yeah. The kind of, most people I talk to, it's not that they're hungry all day, it's that they're constantly thinking about how I can take in less food today. So it's ever present. It's, some people talk to me from the moment they get up in the morning to the moment they go to bed at night, they're thinking about weight and food in some way, shape or form. And the amount of brain space that takes up for people.
Yeah, it must be exhausting. Yeah.
Exactly. And you take that away from them and they kind of feel this freedom. They're kind of saying, I don't have to worry about it. I can go for dinner. I can go out for dinner. I can meet friends. I don't have to be constantly worried about it, because I know I'm protected. I know I'm supported by kind of the medication or the behavioral changes or the surgery, or whatever the treatment might be. So again, the change in our relationship with food, the energy, the joints, for some people, if they have medical issues, the improvement in blood pressure or cholesterol, the ability to get down on the floor and, mess around and play with their kids or grandkids, all of that is kind of stuff we don't see if we focus purely on the numbers on the scales. The scales, and I'm often asked by people, should I be weighing myself? Should I be checking my weight? And kind of, I leave that entirely up to people. I don't weigh people. It doesn't change what I do. Yeah. It's not important to me. It's not the marker of success to me. Yeah. It doesn't help me hugely in my decision making. I base it on health and talking to people. Some people will weigh themselves, and that's perfectly fine to kind of track, depending on how much and how often they're doing it. For some people, if we see a number on the scales that isn't what we want to see, it can have a very negative kind of impact on us. So for some people, it can be helpful, for some people not. But it's not the be all and end all.
I was going to ask you what you like about your job, but I think you've kind of answered that, actually. I think that privilege and that... And I think it's sharing in that success and,
And for the same kind of reasons that I'm sure, and you talk about kind of treating women for menopause and women's health, it's an area that previously I felt totally at sea, not knowledgeable about, and now I feel I can kind of give people the right information and help kind of support them. So what previously terrified me, now I feel like I can kind of talk about these things comfortably, share an understanding and help support people. So that's a huge kind of privilege. But it's actually a very selfish area of medicine when you have people coming back to you.
So in terms of women's health, I get asked a lot by women about how maybe their hormones changing through perimenopause or that loss of estrogen that happens at menopause, how that affects the potential for weight gain, their body shape. A lot of women, if we, they come in and we obviously open the consultation usually by trying to pin down what are their main issues and concerns. And I am shocked on a daily basis how really it's the majority of women will put it really top of their list. They maybe have hot flushes, their mood might be affected, but almost across the board, universally, women will mention, I've had issues with weight gain. And they'll specifically say, I used to gain a bit of weight and then I'd make a few changes and it would come off and I could keep it off. And now that weight gain has gone on and I can't move it. Why is that?
So I think it's a bit like everything. It's very individual. You can look at, for the same reason that some women don't have severe menopausal symptoms, some women don't have kind of issues with weight around kind of time of perimenopause, menopause. But for some, it can have a big impact on both weight, but also body composition. So if we look at kind of, population-based studies, large populations, there isn't a huge spike in kind of weight overall at the time of menopause, but for some women, there can be a major change. So, if somebody has issues with their weight before menopause, then that's a risk factor for further weight gain around menopause. If somebody has more severe symptoms of menopause, that's a risk factor for weight gain. And if we look at a lot of the symptoms of menopause, which you have kind of given me a huge
educated you on,
insight into, we know, so let's say lack of sleep. Lack of sleep can have a major impact on weight. If we see kind of pain, discomfort, hot flashes, being uncomfortable, all those things can have a major impact. Kind of energy levels, stress levels, anxiety, all those things can have a major impact on our weight. So kind of when we lose estrogen, the symptoms that gives us, can contribute to weight increase for a lot of women. But over and above any changes on the scales that somebody might notice, it's the change in body composition that can be one of the most kind of terrifying thing for people.
So that loss of lean muscle mass, but change in body shape too, right?
Yeah. So we know that when they look at kind of these adipocytes or adipose tissue or fat cells, there is a change in the metabolism and behavior of fat cells when estrogen reduces. So you're constantly telling me about all the different areas of the body that estrogen has an effect on, but it has an effect on fat cells too. So fat cells that are located kind of around the thighs and bum and chest, there is a kind of reduction in those cells. So women are not as inclined to put on weight in that area. There is a change in the metabolism of fatty cells around the midsection. So women are much more prone to putting on weight around the middle. That visceral adiposity, that can have an impact on health. So all of a sudden, even if somebody's weight is not changing, the shape of their body is changing.
And the textbooks, in a really horrible, condescending way, talk about changing from a pear to an apple. Isn't that correct?
And I've said that once, and you slapped me across the face for it.
Not literally, but like, I don't like that kind of oversimplification that we're all kind of the same as a fruit or whatever. Like, I don't like it. I think it's insulting to say that you were walking around like big blobby apples, but like,
and it's the same way as you talk about kind of, around time of puberty, the changes in our body that happen and how that loss of control and how it's so disconcerting.
Totally hormonal, isn't it? Yeah.
Hormonal. And the same thing is happening during menopause. And again, the changes in those hormones is affecting what's going on in the brain, our eating patterns and behaviors, the other stuff in life that women are having to deal with, aside from all these physical, psychological symptoms. People lead busy, stressful life. Humans are created that as we get older, we are supposed to put on some weight, but over time, some people will put on more, again, because of our biology.
That's protective though, isn't it? That
to a degree, it is protective in kind
like
of
some
human
weight
evolution.
gain is healthy.
In evolution, it has been, but in the environment we now live in, with the types of food that are available and the stresses and challenges,
generally,
then that's what's causing an issue. And on top of everything else women have to deal with, they're also dealing with weight. And again, it feeds back into society and our views of health and our views of kind of aesthetics and beauty. That people are told that this is their fault. Again, it comes back to biology. This is not our fault. It's a medical issue, and treatments are available that can help manage it.
And I get asked about HRT, about hormone replacement therapy, and whether or not it has an impact on weight loss or weight gain. And I think a lot of women are actually scared potentially at taking HRT because there's a myth that it does cause weight gain, but it doesn't, as far as I'm aware.
In the studies, it's been shown that, now again, we talk about it's weight neutral.
Yeah.
And again, that's the experience of studies. Now, obviously for an individual person, different things can be happening, but in general, HRT does not cause weight gain. There are other medications that can cause weight gain that some women might be taking around the time of perimenopause. Certain kind of antidepressant type medications sometimes can have an impact on weight. If somebody's on steroids or different things, that can affect weight. But HRT is weight neutral.
And there are studies, I think, that have suggested that with this replacement of estrogen, that we potentially see a change in how those adipose cells behave and how they are how they are created in your body. And so we see that translates for some women to a reduction in type 2 diabetes, which is encouraging too.
Yeah, so again, if we talk about kind of in perimenopause, you know, when estrogen is falling, if a woman is supported with HRT, that change in body composition can be abated somewhat, and you know, the body composition, you know, muscle mass, bone mass, and distribution can be changed, and they can be supported in that.
Okay, very quickly, 3 take-home points. If you had a patient sitting in front of you today, they're worried about their weight or they've concerns, like bullet point it for me. What are the 3 most important things for people to take home?
I think big things. Number 1, our weight is not within our control as much as you like to think.
Number 2,
regardless of our size, we should all be focused on healthy eating and physical activity. And number 3, there are safe, effective treatments available if we feel our weight is having a negative impact on our health. And I would encourage people to discuss things, you know, in an open way with their doctor, with their practice nurse, kind of, you know, in their family. We should be talking more about this. We should be talking about why it's not our fault. We should be supporting people. And I think, you know, again, looking kind of day to day at, you know, all we can do each day is do our best. You know, living our healthiest life, and ultimately our weight is going to end up where it's going to end up. But again, that might be in a different place with behavioural intervention, medication, or surgery. Okay,
fantastic. I never even got to tell my story of the, which is totally your fault, the embarrassing patient encounter I had about 2 or 3 months ago.
I'm nervous now what you're going to say.
When I was saying goodbye to a patient on the phone and I was wrapping up the consultation, said, that's great, okay, bye, love you. And then I put the phone down.
Well, that's better than the other story where you had your stethoscope around your
why
neck.
Why did I open this
you were wearing a lovely
box?
frock, a lovely dress, and you bent down to pick something up and you lift back up and the stethoscope grabbed your skirt, so you flashed your knickers at the patient.
I know, my God, the pitfalls of our job, huh? Okay, well, on that note, thanks for sharing that. On that note, we will wrap it up. It was great to have you. I'm glad we had a great conversation. I hope people enjoyed.
Thank you so much for joining us on the Key for Her podcast. We'd be so grateful if you could hit subscribe, rate, and share this podcast with your friends.
For tips, tricks, and hacks on all things perimenopause, menopause, periods, menstrual cycles, and skin health, follow us at Key for Her on TikTok and Instagram.
Check out our website keyforher.com for more information.